All right, so our next section is all about ACLS. So it's a good segue. All the different, electrical problems can lead to these arrhythmias, but also you have to know, when you're getting a patient that they could arrest at any time, or they might go bradycardic at any time, or get tachyarrhythmic at any time, and what to do about it. So that's what this section will kind of focus on, the ACLS part. And also we're going to start from a patient that fully arrests, a fully bradycardic arrest, PEA arrest, asystolic arrest, to a VTAC, VFib arrest, right? And what to do afterwards. We'll touch on TTM a little bit, and we'll talk about bradyarrhythmias and tachyarrhythmias.
That rhythm looks sus.
Code Blue, ICU.
Okay, fam, what's the T?
64-year-old simping for Jesus.
Bill, those compressions are dank.
Not me saving a life while manifesting sinus rhythm.
Vibe check.
Tell me you need shock without telling me you need shock.
Big yikes. Squiggly lines. Fine as shock.
This ain't it, Chief.
Everybody ghost. Full send.
Hey, you're done.
Ratio.
Big L.
He didn't understand the assignment. He's canceled.
Okay. All right, so like mentioned, we've got to be ready for a code at any point or decompensation at any point. So we want to be ready for the unexpected. So before you do code your patient, you want to know the code status. Are they full code, DNR, DNI? What are we doing for this patient, right? And should they be? So that's something also to get goals of care discussion, right? When the patient starts decompensating, you want to get family in there, family involved, let them know what's going on so that we can, get everybody on the same page. Okay, and how do you know that they are full code? I mean, in the computer, we want to make sure it has the code status. So there in red is obviously not correct. So we want to make sure when you get a report that you're eyeballing what the code status is and make sure it's accurate too, because they'll tell you it's DNR, DNI, but it doesn't say it there. We all need to be on the same page. Okay, and then monitor your vital signs, right? So make sure you're monitoring your own vital signs. Every, not your own, but your patient's, every 5 minutes, 15 minutes, whatever it may be. The sicker the patient, you might be doing every 3 minutes, right? And once they start stabilizing, every 10 minutes, every 15 minutes, usually for the more sicker patients, once they're somewhat stabilized. And then after that, you can do every 30 minutes, but at least every hour in the ICU. We need to be monitoring our vital signs, right? And then make sure you can see your other patients, right? You want to be doing a bed bath or doing a procedure and your patient's vital signs is fine, but then your other patient's vital signs are really bad, right? We do have a second set of eyes who are the monitor techs, so they will call you, hey, your blood pressure is low or your stats are getting low, but you don't want to rely on that. They're watching like 35 other patients, all right? So you want to make sure that you are assessing your other patient's vital signs at all times, right? So you click the little other button down here and hit data and pages. I think it's data and pages, and then you find your patient on the list and you select it. So then half your screen is your patient, or both your patients. Half your screen is your current patient, the other half is your other patient. So you can always see your other patient at all times, right? And then alarms, right? You don't want alarms going off all the time. You should be at 20 above, 20 below. So if your heart rate is running 70, that means your heart rate's set at what? 50 and 90, right? 20 above, 20 below. If the heart rate's hitting 120s all the time, you want your low heart rate alarm to be what? At least 100, right? So if it's 120 heart rates, they're attacking away, 120s, 130s, you do want like 100, 110, right? It happened to me where I was covering a nurse from lunch and how your patient's doing, they're doing fine. This one is this one full code, okay, good, go, bye. And then come to look at the monitor, they're both heart rate 60. Okay, that's all right. But one patient's heart rate of 60 was 130 5 minutes earlier. So that's a problem, right? So if it went from 130 to 60, they're bradying down for some reason, right? They're getting more hypoxic, they're getting MI in their hands, something's happening, right? So I wanted to be made alert at 100 or 110, right? If it's 130 down to 100, maybe the fever broke, right? But if they're going 130 and nothing's changed, and now they're down to 60, that means the medulla, which controls your SNS, which is firing off that fast heart rate, is losing its oxygen supply, or the pH is getting too low, the enzymes get denatured, things are happening that are making them more sick, right? So hypoxia will change from sinus tach to sinus rhythm to sinus brady to PEA, right? So the heart rate of 60 didn't have a pulse. So, luckily was able to assess and like, well, shoot, there were 130s before, and now is this patient okay, right? So we want to make sure that we are setting the alarm appropriate. And also, you don't want it to be going off all the time, right? It's like, oh, I want to, if it's hits 100, you want to keep it at 100. You want to then lower it again, right? You want to keep it there all the time because then you start getting alarms going off and off and off. And if you look at, on average, is about 770 to 800. Where is it at? 942 alarms per patient per day, right? And if we have 18 patients, that's 18,000 alarms that are going off, right, throughout the day. And every single alarm machine has more than one beep, right? Your Laris pump has a OK beep or get the heck over here beep, and there's another error beep that your thing's unplugged, and then your vent has like 7 different alarms. Your feeding pump has 2 alarms. There's all kinds of alarms going on. I always want to set up a Jeopardy at the Christmas party just so you can identify which beep it is. By the way, there's a so you say, oh yeah, that's a feeding pump, right? But anyways, you don't want to have those going off forever because how many of them you actually get out of your seat to fix, right? And they found that it's about 99% are non-actionable, that we are not getting up to fix, right? So you want to make sure they are alarms that you want to see, right? So for instance, that same example from the good nurse set their heart rate at 100 and the patient was 130 and it's going off, but this one over here has a feeding pump going off. That one has a low SAT alarm going off at 89 when it should be like 87, right? And this other one has one going off as well. The monitors are hearing those too, and they're also hearing their patients on the floors going off at all times because they're off the monitor. And it's a perfect storm where nobody's going to hear things go off, right? And they found there's 862 deaths in the average of 8 years, where about 60 patients per year are dying because of these, right? And we've seen this here as well, where they were off the monitor, or this didn't happen, I didn't notice, right? So that's the point of setting your alarms appropriately, so that A, you're not getting nuisance alarms, and B, that you respond to alarms, right? You have actionable alarms. And at the same point, you want to make sure that we don't get desensitized, but also it's causing delirium for the patient. It's going off all the time. That's not a nice environment where 5 out of 8 pumps are going off all the time, right? We want to make sure that we are having pumps that are going off effectively and alarms on our monitors that are set appropriately as well. Okay, so alarm fatigue is a real thing. And then equipment, right? Want to make sure you have suction setups at the bedside, right? How many suction setups? It's not 0, right? So if you just have the lid, doesn't count. That's not partial credit, right? If you just have the lid and the container, that's not partial credit, because then you're doing like siphoning, like an RV camp, right? Right? We're not doing that, right? We're going to make sure that we have the suction regulator working. We want to make sure we have the equipment. There's a long tube and a short tube. We want to make sure I have all the things for a setup, right? They can still be in the package, the tubing and such, but you want to make sure you have all the necessary equipment, right? And then what else? You want to make sure you're cognizant of the crash cart location. You know where it's at. If your patient's getting sick, you want to be able to eyeball the crash cart in case you need it, or even bring it close by, right? If you can touch base with your charge, should I have the crash cart nearby? And sometimes you should. And sometimes the patient next to you, who's not your patient, needs the crash cart. So then what do? Where are you going to get the other crash cart from? Well, there's one crash cart per station, but also we can go to PACU and steal their crash cart. We can go to radiology. They've used a crash cart once in the last 5 years. There's different crash carts we can assemble, right? As far as the Zols, that's the most expensive part. We can actually get a physical crash cart, right? So if like one next door was, we can maybe swap the Zol real quick. But at least we have all the materials of the crash cart available to us. Right? And then what else? Ambu bags. We want to make sure you have an ambu bag. We keep an ambu bag in every room right now. So you want to make sure that you have that available. One that is not the previous patients that's opened. You want to make sure you have one ready to go. Okay. End-tidal CO2. We spent a lot of time talking about end-tidal CO2. So you should know that that is important to have that in place, especially for which kind of patients? Vented patients. All vented patients should have end-tidal CO2. If they're really chronic, you can kind of wean them off of it, but if they're an acute patient the first 7 days, definitely need to have a vented patient on end-tidal CO2. And then a sick patient should be on it, and that the sick patient is probably on a ventilator. If they're not, you can have the little nasal prong end-tidal CO2 monitoring. And what else? We can also have, we want to have end-tidal CO2 for a patient who's like post-operative, yes, but also post-procedure, right? They gave anesthesia and they came back to us. We want to make sure their end-tidal CO2 is not going what direction? Well, down would mean they have low cardiac output, worst case scenario, right? From too much sedation. But if they have too much sedation before their blood pressure drops, what might happen? They what? It'll go up because of? They're not breathing, right? So we want to make sure we're keeping track of their respiratory rate. And this is a perfect way to make sure your respiratory rate's not 18 all the time, right? To make sure that, oh, yeah, they are breathing pretty slow, breathing about 8 a minute. And we can then see the end-tidal CO2 start creeping up. And of course, we're going to set our alarms. 20 above, 20 below might be too much for end-tidal CO2. Might tighten that up just a little bit. But yeah, if our end-tidal CO2 is less than 20, that's inadequate perfusion by definition, and they might need CPR. And we've got to make sure they are full code before we do CPR. Okay, and is there a pulse? All right, so assess for responsiveness. Make sure they have a pulse first, right? Don't be assessing a radial pulse. That happened where the RRT charge nurse went out to to another floor and everyone's checking radial pulses. So what are you guys doing? Is there a pulse or not, right? And they're, I can't feel it. It's like, no, move aside, right? And where are you assessing pulses at? In the carotids, right? You can do femorals as well, but you want central pulses, okay? And spontaneous rests, are they breathing, all right? Are they actually there breathing in front of you? They might need to call a respiratory rest, right? To get them intubated or get them perked up. Maybe they need reversal agents, okay? And then what about no NIBP reading, right? You have a NIBP over here and it says X over X. And you finish up your bed bath next door, you're doing something this, you're taking the other patient a CT scan, and this X over X only goes off however often you do it. So if it went off every 15 minutes, like a stable-ish patient, that means 15 minutes, like the blood pressure could have been nothing 1 minute after the first blood pressure. After this is 1602, I think it says, 1606, right? 1607, there might have been no blood pressure. I mean, this went off probably 1630, let's say. And that's, that's a long time where you don't know if they have a blood pressure or not. So in the meantime, if we don't have an arterial line, which measures their blood pressure second to second, what's another poor man's arterial line you can use? There's two of them. What's up? End tidal, right? End tidal CO2 and pulse ox. Look at that pulse ox, doesn't look beautiful, right? That's a pulse ox that is nice and flat, that's not getting perfusion. And of course, we got to compare it to a previous pulse ox. If they weren't getting perfusion to begin with, it's kind of hard to tell the difference. But end tidal CO2 doesn't lie. That's something we can always assess to see if they have good perfusion or not, right? If we do have an A line, you want to make sure you're not losing your A line waveform. That's not good. That means you are definitely losing a blood pressure, or they are moving their arm around and it might get kinked. Okay, and then no pulse ox waveform, no A-line waveform, right? Your diastolic starts going down, your end tidal starts getting less than 20. That is a situation that probably needs CPR, right? We're going to assess them real quick, see if we give pressors, even push those pressors to get their blood pressure responding. Okay, and you don't have a pulse within 10 seconds, 10 minutes, you're going to then start CPR, right? We want to make sure we are, intervening as soon as possible, because early CPR is what saves lives, but also what saves lives is early epinephrine if they have PEA, asystole, and also if they have a VFib or shockable rhythm, early shocking is what saves them, right? Late shocking, late epinephrine, and late CPR all have bad outcomes. All right, so if you don't have a pulse, we are going to be calling a code, right? First thing you want to do is not run away, right? Don't run away and say, oh, my patient's coding, bye, going to lunch, right? So you want to make sure that you are there because you're going to give the history. We want to be telling them what the H's and T's might be. We want to be able to have that resource. Oh, they're end-stage renal. Are we thinking about what was the last potassium, right? And you can pull out the computer to get it going. But make sure you hit the code button, right? It's like you want to be like a good nurse that's BLS trained and ACLS trained. It's like, oh, I got PE in the monitor, CPR, here I go, right? And then all of a sudden you're like, why is nobody here? All right, so I called a code, nobody hear me, right? The other person's in their room over there, right? The chargist is in the back in C station. So you want to make sure you are setting the response overhead so everybody comes there, right? Because the intensivist might be in the call room, you might have someone else in the charge at lunch. There's all kinds of situations that might happen. So you want to hit the code button. That's the first thing to do, is to call for help. The only time you don't call for help is in pediatrics. Pediatrics, you give them a little CPR first for 2 minutes, and then you call 911 for help. But otherwise, for all adults, you want to hit the code button first after you assess they have no pulse, right? And we're doing compressions, airway, and then breathing, right? We're not worried about airway breathing just yet, right? If they're vented, they're on a vent. That's going to deliver volumes. You're perfectly fine, right? You don't have to disconnect from the vent technically, but they usually do, right? But CPR is what's the most important if something's heart stops, right? It only provides a little bit of perfusion. It barely hits that 40 of coronary perfusion pressure that they need, right? That's kind of the goal, the whole goal of CPR. Okay, you want to shock as soon as possible and epi as soon as possible. They found that giving epi at the 2-minute mark is not beneficial. Giving it as soon as possible if they need it, or for PEA asystole, is what you need to do. So PEA asystole is obvious. It's a flat line. What is PEA? A pulseless electrical activity. So you have something on the monitor, you have braided card, you have anything but VFib, VTAC on the monitor basically. You have a secondary type 1 with a PVC and a non-conductive PAC, and it has a little bundle branch block and it has a little extended PR and the QTC is prolonged, but there's no pulse. I don't care about all that stuff. There is no pulse with this rhythm, right? So if you have no VFib or VTAC and no pulse, you are doing CPR and epi, right? And you want to get the epi as soon as possible. That is what shows the best evidence, is giving epi as soon as possible, right? So give it as soon as you can. They found if you give it later, the best outcome they're going to have is to give it as soon as possible, because P-asystole has horrible outcomes to begin with. So to get the best chance of 30-day discharge or leaving the hospital alive is to be giving, yes, CPR, but also giving epinephrine as soon as possible. All right, on the flip side, if we do have VFib, VTAC, that is a shockable rhythm, you want to shock them as soon as possible. You don't want to wait to the pulse check or something. You want to shock them as soon as you can. As soon as you have the pads in place, you want to shock as soon as possible. And usually the pads do get put in place if they're not already on it ahead of time. But you'll see nurses get the pads in place when they see the patient start decompensating. It's like, okay, we're putting the pads on, getting the crash card in here, and they're all ready to go. We don't want to wait until the patient actually codes, right? We want to get those things in place in the first place. And you want to shock as soon as possible, okay? And always look for reversible causes, H's and T's, which we'll talk about coming up. All right, and when you do CPR, to make sure you're not interrupting, right? You might have someone like wants to do a little echo of the chest. It's like, wait, I want to see it, right? I've been asking for a little USB flash drive, because you can do that during the 10 seconds of pulse check, and you can hit record, and then you can look at it afterwards. You can scrub back and forth. So that's, that might be happening, or they say, oh, no, I need to put an airway in, and they're, oh, it's difficult. You don't really have to intubate a patient during CPR. You can put an LMA in. There's all kinds of different options we can use, and if they're vented, they already have the vent hooked up, or someone's bagging them, right? And if they do bag them, how fast should they be bagging them? You got to eyeball them, make sure they're bagging how fast. So it's 10 breaths per minute, or every 6 seconds they should be bagging, right? You don't want to do too much, because when you bag a patient, that's going to put positive pressure in the chest, and positive pressure in the chest is going to reduce increase afterload, reduce the amount of coronary perfusion, right? So that's why they've reduced it all the way down. Okay, you want to be compressing as fast as possible, right? Baby Shark is a good song to sing in the room, right? You'll get a lot of good looks when you do that, right? And then you'll make sure you have good chest compression with a good recoil. This is all BLS stuff that we make sure is very well controlled, is tight. Okay, and then how do you know that you are doing good compressions? You want to make sure that your end tidal is in place, and if you got 8 to 10 millimeters of mercury at least, you have good flow, good adequate flow. And we have an A line in place. As long as your diastolic blood pressure is above 20, that means you have good compressions, right? And in witnessed and unwitnessed arrest, okay, again, do a rhythm check, defib as soon as possible. We've known this since 2018, that we want to defib as soon as we can. As soon as we have the pads in place, as soon as we can shock them, then that's it, right? And sometimes if we don't have IV access, we can give things down the ET tube if we have to, right? So the acronym is lean or naval, right? So lidocaine is good. You could give epinephrine, atropine, Narcan can even be given as a reversal agent, right? So that's the idea behind a code situation, right? So we're always doing CPR and epi. That's usually always the default, right? Only some rhythms get a shock, right? Which rhythms get a shock? VFib and VTAC, right? And there's another medication you can throw in there for VFib, VTAC, which is which medication besides CPR and epi? Yeah, amio, right? And amio is 3 syllables. So after 3 syllables, that's where you can give after 3 shocks, right? 3 syllables, amio. That's when you can give amiodarone. Let's just try it out, right? So amio.
Very good. Okay, we want nice, steady compressions. Look at Trap. That's CPR that'll save a life.
Oh, thanks. I used to be a lifeguard.
What did you do?
I don't know!
Where am I?
You were too good at CPR!
You saved my life. How can I ever repay you? You saved me.
He's moving.
You saved me.
He's moving.
No, for real. Why didn't you save her?
I tried!
You have to have steady compression, Steve.
Somebody help me. I don't have any arms.
What's happening? Oh my God!
What did you do?
Trap, no!
All right, so good effective CPR.